Welcome to Compassionate Conversations. The goal of our podcast is to explore topics related to serious illness. Ancora Compassionate Care exists to be a supportive presence for life's journey. We can provide care and support wherever a patient may be on their journey with a serious illness. Ancora Compassionate Care began as Hospice of Rockingham County in 1987. While our name changed in late 2023, we are still the local provider the community has always known. We'll always be there because we've always been here. Welcome to this edition of Compassionate Conversations. At Ancora Compassionate Care, our mission is to be a supportive presence for life's journey. We do that in a variety of ways, including this platform, because sometimes support comes in the form of education. That's our plan for today as we dig into some of the myths surrounding hospice or end-of-life care. We also want to help our listeners today understand the difference between hospice and palliative care, and help our listeners understand when it might be the right time to consider hospice. Joining me for this conversation today is Ashley Presnell. Ashley is one of our nurse practitioners here at Ancora and also the Director of Patient Access. Thanks so much for being here with me today.
Thank you for having me.
Absolutely. You know, Ashley, you talk to a lot of people. You talk to a lot of patients, a lot of families. And so when you're talking to folks and we want them to understand what hospice really is, when they first hear the word hospice, in your experience, what do you think tends to come to mind for some people?
I think the biggest thing is most people think that they're giving up. I think that's the biggest misunderstood myth when they hear hospice is that they're giving up.
So when somebody says that to you, and I'm sure in conversations when you're calling somebody, maybe we've got a new referral on somebody and maybe it kind of takes them aback a little bit. We're not ready for that. And that's the reason. We don't want to give up on whoever their loved one is. So how do you turn that misconception around?
So what I generally do is I try to get an understanding of, what's going on with your loved one. Tell me how they were 6 months ago, how they are now, and what would their life look like if they could make decisions. If somebody's bedbound now, what would they choose? What would they want for themselves? And I try to explain to them, we're doing all these things to people, but what are we really doing for them? I try to focus more on comfort. Would your loved one want to be in their home, receiving care in their home, or do they want to go back and forth to the hospital? Would they be more comfortable in their home, or would they be more comfortable in the hospital? And just really getting the picture of what would your loved one want.
It's interesting. So a couple of things that you just said, a question came to mind. What's the significance of the 6 months? What makes you choose that time frame?
That's so Medicare says that hospice is a 6-month benefit. And there have been studies that have shown that patients who are on hospice services actually live as long or if not longer with hospice than they do if they don't receive hospice.
Okay. So you're really trying to gauge, I guess, what kind of changes have taken place. I would imagine sometimes, and when we're with our loved one all the time, until that question is asked, they may not even realize, because you're with them day in and day out, right? But there could be a big change. Maybe somebody was walking independently 6 months ago and now they've got to use a walker, or now they need more rest breaks in their wheelchair. So that's an interesting concept for people to think about. But what you just said about we do things to people instead of for people, talk about that a little bit more as it relates to hospice.
So I think in our society, in our healthcare, we want to treat everyone, we want to cure them. And a lot of these diseases are not curable. They are progressive diseases and they will get worse as time goes on. And there has to come a point where it's like, I want to stop getting these treatments. I want to stop getting lab draws or tests or chemotherapy, whatever the treatment is. They're not making me feel better. They're just prolonging a life that has no quality to it. And I just feel like we're constantly doing things. Those are the things that we're doing to people. Instead of letting them decide, I just want to stop everything. I want to live my life comfortably and I want to live my life in my home. And
and being in your own space. I think sometimes I think about people kind of get in the habit, especially folks that have been dealing with a chronic condition. Maybe this has been a long-term situation, and they're used to, if you will, back and forth to the ER, back and forth, and maybe have a hospitalization once every 2 months. Then it gets to be once a month. So when you see people like that, if that's been their history, I would imagine that it's kind of hard to say, I just want to stop everything. But to change the focus, so I guess one of the myths is it's not about giving up, but we do have to change the focus to the quality of life. And that, of course, looks different for everybody. I would want to be in my own home, and I would want to have say-so about how everything goes.
And a lot of those patients who are in the hospitals, you know, back and forth to the hospital, I try to explain to them, you know, you go into the hospital and let's say you have COPD, going for COPD, and your level of function was here before you went in. You have a COPD exacerbation, so your function and your respiratory status decline to, let's say, here. You go through the treatment, they help you improve while you're in the hospital, you return home, but you're here. You're not back to where you were. And that's the decline that I try to show families. You know, you have improved from your exacerbation, but you're not back to where you were. And that's the progression of most diseases, is that you'll have declines, you'll improve some, and then you'll continue to decline. And that's just, I try to help them see the picture that they already have in front of them, but like you said, they just don't see it because they're living it every day.
Right. And it's hard to step back and keep all of that in mind. So, okay, so we've just kind of gotten rid of one myth. So hospice is not about giving up, but we do change our focused on quality and comfort. And it is interesting, you did point this out, but there's so much research. Once we stop back and forth, you know, that takes a lot of energy.
Right.
Getting in the car, going to the doctor, going to wherever we're going back and forth to the hospital, all the sticks, maybe it's IVs, maybe it's lab work. Well, when we stop all of that and you can stay in your own space, people do tend to live longer, and you get all this incredible support through hospice. So another myth, you mentioned that hospice is a 6-month benefit. So why in the world do we have so many late referrals? I think certainly the myth of you don't call hospice until we're right down to the last few days. Yeah,
that is a huge myth, that you don't call them in until the very end. And a lot of patients, I know, once they get on hospice services, they do say that I wish I would have called hospice sooner.
Yep. Oh my gosh, if we had a dime for how many times on the back end somebody said, I just wish, if I'd known you all did this, this, and this, I wish we had called you sooner. You know, years ago, and this is certainly not a slam on physicians. We got some fantastic physicians here in this county, but I actually had a physician call me because we had gotten a referral from somewhere else. I called for the order for hospice, and he said, he's not ready for hospice. He still goes out to eat. And my response was, we want him when he can still go out to eat. I want him when he can go to the beach, if he wants to, and when he can go to the family reunion if he wants to. He's still going to church. That doesn't mean he can't have the wonderful support, or that he's not still appropriate for end-of-life care.
And I think a lot of the reason that, you know, people think that it's just the last days of life and people actually do live longer on hospice is because we're managing their pain, we're managing their stress. And, you know, when you take that stress burden off of someone who's just worried about, you know, what is my next treatment? What am I going to do about with this? What am I going to do about that? It really, truly does help you live longer.
Right. Well, there's a tremendous amount of that emotional and mental health support that goes along with hospice care, that it takes a lot of that burden away. So that's a very good point. In the first days of hospice, we're talking 40 years ago when this all started, the majority of what you would hear about would be patients who have cancer. So sometimes I think that's another myth. People don't realize that there are many other diagnoses. As a matter of fact, here at Ancora, the majority of the people we care for with our hospice service line don't have a malignant diagnosis. So what other diagnoses do you see that we can support?
Oh, there's a lot. So COPD, or chronic obstructive pulmonary disease. We have dementia. We have heart failure. A lot of times malnutrition. And a lot of people, worry when they hear the term malnutrition. But a lot of times in diseases such as dementia, a lot of patients do not want to eat, and they do become malnourished towards the end of life. So there are a lot of different diseases that we do treat.
So basically, any chronic condition that you can name that has no cure, right? Eventually, we will be at the end stage of life, and that's where we can step in. So we're talking about hospice, and I match that is end-of-life care. I don't think we've done a good job in healthcare overall, helping people understand the difference between hospice and palliative care. So can you speak to that just a little bit?
So yeah, like you said, we call our serious illness care, which is also palliative care. So the biggest difference with those is, so they both can provide care for any serious diagnosis, but the biggest difference is with serious illness care, you continue to receive treatment, whether it's chemotherapy, aggressive treatments for heart failure, COPD, or dialysis for end-stage renal disease. The goal there is to manage those symptoms and also discuss your goals of care, and hopefully improve your quality of life. And the biggest difference with hospice is that you're treating those diseases, but you're focusing on comfort.
Yep. So we've got our serious illness care clinic. And the way I have helped people understand the difference as far as Ancora is concerned is that this is a consultative service, just like you would go to your cardiologist, go to your oncologist, dermatologist, whatever. So our nurse practitioners with that program are working with the patient's primary care physician and to help manage. So it's kind of like a supplement, if you will, lack of a better word. So, but it's just one more layer of support. But, one way I was describing this too, we had some nursing students here in Gibson House doing some of their clinical a couple of weeks ago. And one flat asked, what's the difference? Because we hear palliative care when we're in the hospital. And I said, well, the easy way for me is really to use the time frame. So palliative care or hospice is always palliative, meaning we are working to control symptoms, keep people comfortable. But palliative is not always hospice care, and it is that 6-month prognosis. That, of course, is a Medicare regulation. So hopefully that helped them understand that a little bit better. And with palliative care, or what we call serious illness care, you can be years out from the end of your life, right? Okay. So when we get a referral and you're reviewing medical records or talking to the patient family and you're getting a history from them, what sort of things come up that kind of clue you in that it might be time to consider hospice for this person?
So it just depends kind of on the disease process itself. A lot of times I'll look at how many hospitalizations they've had, how many ED visits they have, if they've had any weight loss, or sometimes weight gain if they have heart failure, because a lot of times they're retaining fluid. Other things I'll look at is as far as what treatments they're receiving. Sometimes we'll get referrals from the hospital and they'll kind of have like a brief discussion with them as far as, what are your goals, things like that. If it's a patient who has a type of cancer, are they still getting aggressive treatment? Has it spread? Has anyone discussed with them, this is kind of how the treatments are going to go? What are your goals as far as that? So it just it's based off of different aspects that I pull from the chart depending on what their disease is.
Okay.
What I'm looking for.
And some people don't realize there's a huge piece that really has nothing to do with your diagnosis. I think about things, you mentioned the weight loss, but I think about falls. How many falls has this person had, if they've had any, but how many in the last few months? And also back to what you said earlier about what's the change. What is this somebody that is now using a walker who wasn't 6 months ago, things like that. But something I think that people don't think about is how much more help do they need with their personal care? Can they get their bath or their shower independently? Can they get dressed independently? How many rest breaks do you have to take while you're doing that? And all of that together can kind of start painting a picture that might be time to consider.
Yeah, one of the big things that I always ask the families is, what could your mom or dad or whoever I'm talking about, your loved one, what could they do 6 months ago that they can't do now?
And what sort of things do you hear?
I hear all kinds of things. A lot of times it was, well, mom could drive 6 months ago and now she sits in the chair all day, or, mom sleeps a lot more during the day. So those are things to look for. You're sleeping more, their appetite has declined. And the big thing is, they'll say their appetite's good, but, what is good? Tell me how many meals they eat in a day. How much of that meal do they eat? So weight loss is a big indicator. Like I said, the emergency room visits, the hospitalizations, those more frequently. And like you're talking about the functional status as far as getting to the bathroom. They could go to the bathroom on their own, but now they need assistance, or they're no longer able to walk anymore. Those are big indicators that hospice may be appropriate.
Okay. So we talked about the myth of we don't want to wait until we've just got a few days to a couple of weeks, right? What are the benefits of starting hospice as soon as possible?
Well, it gives our entire team time to really know the patient and know the family and understand their needs. We're able to better assess the patients, figure out what symptoms they need managed, what the family needs from us, what support they need from us, what support the patient needs from us. That's hard to get all that information in just a day.
Yeah. Well, and I've always had the thought that and you mentioned the whole team, so we're talking a nurse that's assigned to that patient, but you've got a nurse that's available 24 hours a day, the hospice aide that can come help with personal care, wonderful social workers, wonderful chaplains, and volunteers if they choose to use that service. So you've got this whole team taking care of their physical health, mental and emotional support, helping with that personal care. We're taking care of all the medications. We're taking care of any medical equipment that you might need. So when we don't have time to do that, hospice care to me can become crisis care, and that's not what we want. And then I think it just perpetuates that myth in the community that you don't call us until we're right at the very end. Yeah. So one of the things that we're really going to start focusing on more with families, you've touched on it several times, but talking about what are their goals, but what's the most important thing to that patient and family? Maybe they do want to get to the beach one more time, or they want to be here for great-granddaughter's wedding. That's also part of the reason. Let us come as early as possible, and we'll see what we've got to do and put in place for you to help you achieve what it is you want to achieve. So huge quality of life issues. But if somebody's listening right now and they're not quite sure if hospice is right or not for their loved one, what's their first step? What do they need to do?
I would say call us. We could send out a nurse to do an assessment on your loved one, and they can answer any questions you have. It's not something that you have to, sign consents for that day. We can give you all the information, answer all your questions, and we can do an assessment and help point you in the right direction.
Okay. So we've got a wonderful intake department that you supervise.
Yes.
Yes, they are fantastic. So truly, all somebody has to do is call. They don't have to wait on their doctor to call.
Correct.
They can call and refer themselves. It happens more times than people might think. They can refer their loved one. And, we've had several recently that the nurse does go out, does an assessment, and for whatever reason, that patient is not admitted to hospice that day. But in my mind, that is still a win for that family because you've heard no misinformation, right? You got it straight from the horse's mouth, so to speak, so you know the truth about hospice, what we actually do, what we can do if you choose to use our services. So that gets rid of a lot of those myths. And it might be, hey, it's just a little too early, but now this family's been educated and they know exactly when to call.
Right.
So our admission nurse can give them, hey, if you see this, this, or this, then you give us a call back. So, okay. So as we're wrapping things up today, Ashley, what is one thing that you wish people understood about hospice?
I think the biggest thing is that hospice is not giving up. It's just changing your focus to comfort.
Okay.
It's not giving up.
Yep. I appreciate you being here
Thank
today. Yeah. If you would like more information about our hospice service line, our serious illness care service line, or even our counseling center for mental health support, give us a call today at 336 427-9022.